Bismillahirrahmanirrahim. Today we are going to start with the gynecology. So let's get straight into this. The first topic of the gynecology is menstrual cycle. In the menstrual cycle, let me zoom it in. So there are parts of the menstrual cycle. The first one is ovarian histology, that changes during the menstrual cycle, then anterior pituitary hormones, ovarian hormones, and then all of that affects on the endometrial cycle. So basically there are two simultaneous cycles occurring. One is ovarian cycle, second is endometrial cycle, and they are both influenced by the ovarian and anterior pituitary hormones. So now let's see them one by one. When in the ovary we have primary follicles, the primary follicles are present in the ovaries of every woman even before the birth. Under the influence of follicle stimulating hormone, these primary follicles convert into secondary follicles. Secondary follicles become tertiary follicles, and due to the luteinizing hormone surge that happens on almost the day 14, and FSH hormone also increases, so there is a process that we call ovulation. After ovulation, FSH and LH, the levels just reduce down. If we see, and then the ovum is sent into the fallopian tubes. When it is ovulated, the ovum leaves the ovary and it enters the fallopian tube, while the structure that was left inside the ovary, the leftover of the follicle, that becomes corpus luteum for about the rest of the menstrual cycle, and then by the end of the menstrual cycle it starts undergoing regression, and then it becomes corpus albicans. The first part, until the ovulation, from the starting from primary follicle to ovulation, we have follicular phase, and after ovulation to the regression of the corpus luteum to form corpus albicans, that is a luteal phase. Now, if we talk about the ovarian hormones, so in the ovarian hormones, when the follicular phase is going, the primary hormone is estradiol, and for ovulation, along with the surge of luteinizing hormone and FSH, we have a surge of estradiol as well. Then after ovulation, the estradiol or estrogen that comes down, while the progesterone starts increasing. Why does it increase? Because the estrogen because the progesterone is being produced by the corpus luteum, while this estrogen was being produced by these follicles, right? So the follicles were producing estrogen, and when there was ovulation, there was a maximum amount of estrogen that was being produced by them. Then came the corpus luteum, and then this corpus luteum started producing progesterone, and there was a maintenance level of progesterone that remained in the circulation until the menstrual cycle did not finish. And by the end of the menstrual cycle, there is decrease in the level of progesterone and estrogen as well. So the endometrium sheds off, and then there is a start of a next menstrual cycle after 3 to 5 days of bleeding. Now, during all of this process, what is happening in the endometrium? Now, let me zoom it out a bit more. So, here you can see that in the day 1 of menses, when the woman is bleeding, like during the bleeding phase, the primary follicle is converting into secondary follicle, and the luteal phase begins. So basically, the cycle begins from day 1 of menses till the 14th day. So when there is ovulation, during the luteal phase, there is proliferation in the endometrium, and that proliferation in endometrium causes the proliferation of the blood vessels, and there is proliferation of endometrial tissue that is happening. Once that has happened, then comes the progesterone. This progesterone causes the secretory phase. What does it do? The progesterone helps in making the blood vessels go tortuous. It helps with the increased secretory activity of the glands. It makes the endometrium very soft and conceptive towards the fetus, and that is happening in the secretory phase. So if I sum it all up, so during every menstrual cycle, the ovary undergoes follicular phase and luteal phase, and in the same time frame, the endometrium undergoes proliferative phase and the secretory phase. I hope I could make it clear. Now moving forward to the perimenopause, I'm sorry. It is the menopausal transition which can occur before the final menstrual period. It is the menstrual transition which can occur before the final menstrual transition. Ovulation still occurs during this time. However, conception rates are low. Synonyms are irregular menstrual period, insomnia. They are not synonyms, they are symptoms. During the perimenopause, like it is now, the woman is very close to the menopause, but before menopause, there is a state that we call the perimenopause. So there are some changes that are happening in the woman's body. During that time, there can be irregular menstrual period, there will be insomnia, there will be fatigue, and weight gain. All of these things can happen. Then talking about menopause, so the clinical features: vasomotor symptoms, hot flashes and sleep disturbances, oligomenorrhea and amenorrhea, sleep disturbances, decreased libido, depression, cognitive decline, and vaginal atrophy. Diagnosis is clinical manifestations and increased FSH. Treatment is topical vaginal estrogen and systemic hormone replacement therapy. It is defined as absence of menses for more than 12 months. The menopause means the absence of menses for more than 12 months. I'm sorry. For more than 12 months, this is the definition of menopause. Menopausal transition and initial symptoms may begin a few years before the final menstrual period and commonly occur at the age more than 45. Loss of ovarian function leads to hypoestrogenemia, and then that decrease in estrogen level has some sequelae. They can be vasomotor symptoms, they can be vulvovaginal atrophy, and osteoporosis. So, in the vasomotor symptoms, they can be hot flashes and sleep disturbances. They can be vulvovaginal atrophy because estrogen is not there to maintain their integrity, and osteoporosis can occur because estrogen has plays a big role in inhibiting the osteoclast activity. So when the estrogen is not there, so osteoclast can cause the bone resorption at a higher rate. Rule out thyroid etiology before diagnosing the case of menopause. Menopause diagnosis is confirmed clinically by more than 12 months of amenorrhea. However, in patients without previously normal menstrual cycles like prior hysterectomy or endometrial ablation, the diagnosis of menopause cannot be made clinically because vasomotor symptoms and vulvovaginal atrophy can be due to other etiologies like thyroid disorders and malignancy. So, therefore, these patients require an evaluation of serum FSH for the diagnosis. So, definitive diagnosis of menopause can be made by determining the level of FSH. Okay. So, this is important. So, I just forgot the point I was trying to highlight. Okay. So, they're saying that if a woman is having hysterectomy or maybe endometrial ablation, so she won't have decreased menstruation or like we cannot diagnose it clinically by determining the months of amenorrhea because she is already having amenorrhea. She does not have a uterus, right? So in these scenarios, only the vulvovaginal atrophy or the hot flashes cannot be the answer or cannot be the diagnostic marks because they can also be caused by other etiologies like thyroid disorders or some malignancies. So in these patients, we have to check for the level of elevated serum FSH, right? Okay. So if I come back to this picture, here you can see the follicle stimulating hormone was trying to convert the primary follicle into secondary follicle to make the ovulation happen. If it is not happening, so basically the negative feedback signal for FSH was uh, I guess increased estradiol production, maybe, or luteinizing hormone. So basically, there is no negative feedback inhibition of the FSH production from the anterior pituitary, and because there is no down right effect of the estrogen, that is no downright effect of the follicle stimulating hormone that is happening. So resultantly, the FSH level will be elevated. So increased FSH level is a diagnostic point for the menopause. Then treatment for vasomotor symptoms. Now we can't treat menopause, but we can give the symptomatic care to the women. For the vasomotor symptoms, mild lifestyle modifications like wearing layers, weight loss, severe hormones. If it is very severe, if it is mild, so we can do the mild lifestyle modifications like wearing the layers or maybe weight loss. And if it is very severe, so we can give the hormone replacement therapy. Patients with contraindications to hormone replacement therapy are treated with SSRIs. Hormone replacement therapy indications: Only indication of hormone replacement therapy is vasomotor symptom in women aged less than 60 who have undergone menopause within past 10 years. Contraindication is history of coronary heart disease, thromboembolism, transient ischemic attack or stroke, breast cancer, and endometrial cancer. Treatment of menopause. So basically, we treat the vasomotor symptoms. If they are mild, we go with the behavioral modifications. If they are moderate or severe, then contraindications to estrogen, we check for them. If there are no contraindications and there is intact uterus, so we go for estrogen and progestins. And if there is no contraindication to hormone replacement therapy or estrogen, and there is no uterus, like the woman had, total hysterectomy before for some reason, then we give estrogen only. Okay. And if there are contraindications to estrogen, so we give normal therapy, non-hormonal therapy with SSRIs. Contraindication to estrogen are breast cancer, coronary heart disease, endometrial cancer, liver disease, and thromboembolism. Then we have atrophic vaginitis, also called as genitourinary syndrome of menopause. It is caused by decreased estrogen due to menopause. Normally, estrogen maintains the moisture, blood flow, and collagen content of the vulvovaginal tissue. Symptoms are due to the effect of estrogen deficiency. So, why is there is vulvovaginal atrophy after the menopause? Because estrogen is responsible for maintenance of moisture, blood flow, and collagen content of the vulvovaginal tissue. If it is gone, so there will be certain symptoms which are listed here. There will be thinning of the vulvar skin, which will result in itching, narrowing of the vaginal introitus that will cause dyspareunia, which is painful sexual intercourse, because there is narrowing of the vaginal introitus, and loss of natural lubrication that will result in dryness. And other feature of atrophic vaginitis are decreased valvular elasticity, labial retraction, smooth and non-rugated vaginal epithelium with areas of patchy erythema. Menopause can lead to following urinary symptoms. There will be urgency in continence, recurrent UTIs, and dysuria. So, urge incontinence, why? There is decreased collagen, elasticity and blood flow in the bladder, trigone, and urethra. So, the collagen and elasticity is also decreased in the bladder, trigone, and urethra, which are estrogen sensitive tissues that will lead to urogenital atrophy and urgency incontinence. Recurrent UTIs will lead to decreased glycogen content, loss of vaginal lactobacilli, and increased vaginal pH that will lead to increased risk of recurrent UTIs. Okay, I have to read that again. They are saying that there is decreased collagen, elasticity, and blood flow to the bladder, trigone, and urethra. Got it. And they are estrogen sensitive areas. So this will lead to urogenital atrophy and urgency incontinence. Uh-huh. Then UTIs are happening because there is decreased glycogen content, loss of vaginal lactobacilli, and increased vaginal pH. So that increases the risk of recurrent UTI because the opening of urethra is very close to that of vagina. So if there is increased vaginal pH because of lack of vaginal lactobacilli, so that increases the risk of UTIs for some reason, because I guess that will increase the growth of some certain bacteria that prefer high pH. Yeah. Then not post-coital antibiotics can be given in patients with recurrent UTIs more than 2 within 6 months. Dysuria, which is painful urination, decreased glycogen at the vulva, thin, easily denuded vulvovaginal epithelium that will result in dysuria where the contact with the urine occurs. Okay, so basically two problems are happening. One is decreased collagen and decreased glycogen content. Decreased collagen can lead to urge incontinence, and decreased glycogen content can lead to recurrent UTIs and dysuria. Physical examination will show a pale, easily denuded, retracted, atrophic vulvovaginal epithelium, and that will also result in clitoral shrinkage. Treatment is first line is lubricants or moisturizers. Persistent or severe symptoms, there will be vaginal estrogen can be given. Differentials include lichen planus, lichen sclerosis, and vulvodynia. So lichen planus means chronic inflammatory skin dystrophy. Erythematous valvular lesions with a purple hue and white reticular lines that are Wickham stria may be present in the lichen planus. Lichen sclerosis does not affect vaginal moisture. There will be thin and wrinkled skin, Thickened white plaques obliterate the labia majora and minora. So the thickened white plaques will obliterate the labia majora and minora, and they involve the perianal region as well. So lichen sclerosis involves the perianal region as well. Okay, and it does not affect the vaginal moisture. For the vulvodynia, dyspareunia due to sharp burning pain on the vulvar vestibule, often triggered by touch, for example, Q-tip test, vestibular erythema, no vaginal tissue narrowing or clitoral shrinkage, differentials of urinary incontinence in the atrophic vaginitis. So we'll talk about them. So for atrophic vaginitis, you must keep lichen planus, lichen sclerosus, and vulvodynia in your mind. Okay. Then differentials include chronic bladder pain syndrome and urethral hypermobility. These are the differentials for urinary incontinence in the atrophic vulvovaginitis. Atrophic vaginitis, yeah. So differentials are chronic bladder pain syndrome, bladder pain that worsens with filling and is relieved with emptying, and there are no associated urinary incontinence. Urethral hypermobility, cause of stress incontinence. Got it. Then genitourinary syndrome of menopause. Symptoms: vulvovaginal dryness, irritation and pruritus, dyspareunia, vaginal bleeding, urinary incontinence, recurrent urinary tract infections, and pelvic pressure. Physical examination: narrowed introitus, pale mucosa and decreased elasticity. There is narrowed introitus, pale mucosa, decreased elasticity and decreased jugae, petechiae and fissures, and loss of labial volume. Treatment is with a vaginal moisturizer and lubricant and topical vaginal estrogen. Then vulvar lichen sclerosis. So this is how you see the lichen sclerosis. These are lichenoid patches which are involving the perianal skin as well. So this is pale, thin tissue, and perianal thickening with a fissure is also happening. It is common, benign inflammatory disease, common in prepubertal, perimenopausal, or postmenopausal women. It is associated with an autoimmune disease. Clinical features are vulvar involvement, thin wrinkled skin causing hypopigmented areas and intense pruritus, loss of labia minora and clitoral hood leading to narrowing of the vaginal introitus, dyspareunia and dysuria. Perianal involvement will lead to painful defecation and anal fissures. Vulvar punch biopsy is recommended to confirm the diagnosis and rule out vulvar cancer, which can occur in the patient with a persistent and prolonged lichen sclerosis. Treatment: super potent topical corticosteroids like colbutasol, differentials, lichen simplex chronicus, and streptococcus dermatitis. So we are talking about lichen planus, right? Lichen sclerosis, I'm sorry. So the differentials include lichen simplex chronicus. It is due to excessive scratching and leads to thick leathery vulvar skin. So basically the lichen sclerosis which we are talking about is caused due to autoimmune conditions, and the lichen simplex chronicus is caused simply because of excessive scratching, and that leads to thick leathery vulvar skin. Streptococcus dermatitis, it has perianal pruritus and anal fissures. However, the patient has bright erythematous perianal rash, unlike the pale one which we see in the case of lichen sclerosis, with sharply demarcated borders instead of thin white skin. Vulvar lichen sclerosis, epidemiology, prepubertal girls and perimenopausal or postmenopausal women. The clinical features are thin, white, wrinkled skin over the labia majora and minora, atrophic changes that may extend over the perineum and around the anus, excoriations, erosions, fissures from severe pruritus, dysuria, dyspareunia, and painful defecation. Workup is punch biopsy of adult onset lesions to exclude the malignancy. Treatment is super potent corticosteroid ointments. So here you can see that this is vitiligo. Okay, so this is depigmentation, normal vulvar architecture, and there is no surrounding inflammation. Valvular cancer, etiology, persistent HPV infection and chronic inflammation. Risk factors include tobacco use, valvular lichen sclerosis, immunodeficiency, prior cervical cancer, and valvular cervical intraepithelial neoplasia. Okay. Clinical features are valvular pruritus, valvular plaque or ulcer and abnormal bleeding. There will be friable lesions, typically in the labia majora. The term friable refers to the easily irritated, which means, which makes, I'm sorry, the friable refers to the tissue that is easily irritated, which makes it more prone to inflammation, bleeding, and tearing. And for the diagnosis of valvular carcinoma, we do the biopsy. Perianal streptococcal dermatitis. So this is perianal streptococcal dermatitis, and if you could remember, we talked it in the differentials of valvular lichen sclerosis. This one. So coming down, this is perianal like streptococcal dermatitis. This is the anal fissure. Like this is over here is the anal fissure. Bright red, well demarcated perianal rash is happening. Then emancipated minors. Circumstances in which the minors can provide their own consent. Medical emancipation, emergency care in all states, sexually transmitted infection in all states, mental health, substance abuse treatment, pregnancy care, and contraception. Then there is a concept of legal emancipation. If the child is financially independent, is a parent, married, active military service, and high school graduate. Sexually transmitted infections. So, characteristic of ulcerative sexually transmitted infections. So, we are going to talk about chancroid, genital herpes, granuloma inguinale or dolomanosis, syphilis, and lymphogranuloma venereum. So, firstly, chancroid. The lesion is painful with painful suppurative lymphadenopathy and buboes. So, the causative organism for chancroid is Haemophilus ducreyi. So, you do cry with Haemophilus ducreyi. The features of primary lesion are multiple and deep ulcers. Base may have grey to yellow exudate. Organism often clump in long parallel strands, school of fish, and initial lesion is painful. Then we have genital herpes. So the causative organism is herpes simplex virus type 1 and type 2. Multiple small grouped ulcers, shallow with erythematous base, multinucleated giant cells and intranuclear inclusions, Cowdery type A bodies are present in them and they are also very painful. Granuloma inguinale or dolomanosis, Klebsiella granulomatis, extensive and progressive ulcerative lesions without lymphadenopathy. Base may have granulation-like tissue, deeply staining gram-negative intracytoplasmic cyst or dormant bodies, and the initial lesion is not painful. Syphilis, painless ulcer with painless lymphadenopathy in the first stage. So there is going to be non-tender lymphadenopathy and the lesion is also non-tender.